So good evening, everyone, and welcome properly to our digital glaucoma support group. Thank you so much for joining, and welcome to everyone who's joined this session. We're very excited about our talk today. It's glaucoma and cataracts. It's the first time we've done anything about cataracts and how it interacts with glaucoma. So really, I can see we've got a big audience for today's session, so I hope you find it all really helpful. I'm Joanna Bradley, Head of Support Services at Glaucoma UK. Our speaker this evening is Pouya Alaghband. Mr. Alaghband is a consultant ophthalmologist at York and Scarborough NHS Hospitals Trust. He's here to talk to us all about cataracts and glaucoma. So, for example, how cataract removal might affect your glaucoma, or why treatments for glaucoma might affect a cataract. I'm so glad so many of you have chosen to spend your evening with us. And I'm just going to spend a few minutes talking about the format of today's talk and the technical side of Zoom. So, many of you I know have joined this before, but just in case this is new to you, we can't see or hear audience members, but you should be able to see and hear me and Pouya. We're also being streamed live on Facebook, and if you're watching there, you can ask questions by commenting on the feed. There'll be 2 short polls launched during the webinar as well. These are to help us see the difference the sessions are having, and if you feel like you're learning things. I'm going to launch the first one now, and this will stay open for about a minute or 2. If you're having any technical difficulties at any point in the talk, try turning off any other devices which are connected to the internet at your home, or if you leave the session, you can rejoin it through the same link. And sometimes just rebooting the link can work. So if you'd like to ask a question at any point, please wiggle your mouse or touch your screen and you'll see the Q&A box appear on your screen. Click on this. If you have any questions for Pouya, type them here. You can ask questions whenever you like, and we can see these throughout the session. Even if you don't have any questions, keep an eye on that Q&A panel. If you like a particular question, you can click like, and the most popular questions will come to the top of the list, and we'll try to answer them first. The chat button is best used if you're having any technical issues. So try to keep your questions about cataracts and glaucoma in the Q&A section, and any technical issues in the chat. Just helps us to kind of keep all the questions in one place. We really want this session to be interactive and cover the topics you're most interested in. So please do ask any questions. And the only silly question is one you wanted to ask but didn't. I'll activate closed captioning in a second. During this talk. If you want to switch them on, click on the button marked CC Live Transcript. This is automatic subtitling, which can find medical words hard. So a little bit about Glaucoma UK. We're the UK's charity for people with glaucoma. We work in 3 main areas to prevent glaucoma sight loss. Firstly, we campaign to raise awareness of the disease. We want people to know what glaucoma is and about the importance of getting your eyes tested. The earlier glaucoma is diagnosed, the less likely people are to experience sight loss. Secondly, we provide support and advice to people with glaucoma and those who care for them. We have information leaflets, a helpline, a buddy service, and a patient forum, and we provide training and advice to professionals looking after people with glaucoma. All our services are free. Finally, we fund research into the diagnosis, treatment, care, and prevention of glaucoma. I'm going to hand over now to our speaker, Pouya. So please don't forget to post any questions you have in the Q&A, Pouya. So Pouya, thank you. Over to you.
Thank you very much for the kind introduction, and thank you very much for having me today. Let me see if I can share my screen. Right, good evening, everybody, and thank you very much for tuning in today. So what I would like to cover this afternoon is outlined here. So I would like to try to answer your questions related to glaucoma and cataract and their interaction between the two. I'm going to talk a little bit about glaucoma and its symptoms. I would like to talk about how common the glaucoma is, how it is managed. Then I'm going to delve into the interaction between glaucoma and cataracts, what support's available, and what the future holds for us. So to start with, I wonder if there is any specific questions coming to your mind and you would like me to answer before I keep going. So I'll give you a minute or two to think about any questions you may have before I start. So there's a question here. I've been waiting almost 11 weeks for the results of my DVLA Specsavers test for glaucoma to see if I can keep my driving license. Is it normal to wait this long with the backlogs at Swansea? Yes, I'm afraid, yes. COVID didn't help, unfortunately, at this moment of time. And there is, as you noted yourself, there is a very long delay in replying back to your questions. I'm due to have a trabeculectomy, but also have a cataract in that eye. Is it possible to have a cataract operation after my trabeculectomy procedure at some point? The short answer is yes. The long answer, you need to listen to my talk, and I would cover that by all means. So let's move on. So hopefully we are all on par with each other. So what I would like to start with, usually with my talks, I would like to talk about etymology of the words. So glaucoma comes from the Greek word glaucos, means bluish green gray, and that came from a condition which we call it acute angle closure glaucoma. So what happened is, there are two broad types of glaucoma. It could be called open angle or closed angle. In a moment, I'm going to show you a diagram and go through this in more details. But generally, the eyeball is similar to a football, but instead of being filled with air, it's filled with liquid. And that liquid is constantly produced inside the eye to maintain the shape of the eye and integrity of the eye, and also nourish the eye, and then drained out through the drainage angle of the eye in the front chamber of the eye. Normally, there's enough space for the fluid to reach those drainage angles, but in angle closure, there's just a sliver amount of space left for the fluid to reach that area. And it may come to a certain point, which is like a critical point, whereby the drainage angle of the eye may completely zip off. And that's when the pressure inside the eye shoots up and the acute angle closure happens. So the typical picture is this picture of the eye in the bottom right-hand corner of your screens. And you can appreciate the bluish green-gray appearance of the eye. So essentially what you see, loads of blood vessels, and then you've got clear window of the eye. And then behind that, you see that's a round area, which is pupil, and the color part of the eye. Behind this round area is the lens itself, which is cataract or lens. And essentially, due to the haze in the clear window of the eye, that appears forms, hence the name glaucoma. What about cataract? Cataract, again, comes from Greek word cataractus, means waterfall, because everything is misty as if you're looking through the water. And this is a typical picture of the cataract on the top left-hand corner of your screens. The reason for developing cataract is that the cataract, the lens itself is a living tissue, as it is demonstrated on the schematic picture on the bottom left-hand corner of your screens. And throughout life, these cells will proliferate and reach to the center of the lens. And when they die off, because they are within an enclosed area, they die off and they slough within the lens and become impacted. And over time, there will be a calcium deposit on top of it, hence the cataract forms. So, because if you look here, there is a diagram of the eye. So you can see this is a clear window of the eye. This is the drainage angle of the eye. This is the color part of the eye. And this is the front chamber of the eye, which is filled with liquid. We call it aqueous, which is there not only to keep the shape of the eye, but also nourish the eye. Behind the color part of the eye, the lens is located. The lens is held in its place with little ligaments. And then behind it, we've got a vitreous cavity. So as I explained, this liquid produced from the back of the eye, this area here, ciliary bodies, aqueous, and makes its way through the pupil to the front chamber of the eye, and finally to the drainage angle of the eye. And the reason for having this constant production and drainage is to have a fresh liquid always being present within the eye, so that the nutrients, oxygen, everything is accessible to all the eye tissue all the time. And the balance between the production and drainage is very crucial to maintain the pressure inside the eye. So there are loads of studies done on the amount of fluid produced within the eye to find out whether there is overproduction or under drainage. A majority, almost all of them, confirm that the problem is within the drainage angle of the eye. All glaucoma are, in all types of glaucoma, the amount of fluid produced inside the eye is not increased. In some cases, it may be reduced, but certainly in none of the available and known glaucoma cases, the production of aqueous is not increased. Therefore, the majority of the problems are located in the drainage angle of the eye. And as you can see, there is a close relationship between the lens, the iris, and the drainage angle of the eye. And broadly speaking, depending on whether the drainage angle of the eye is open or closed, we've got two main types of glaucoma: open angle glaucoma or closed angle glaucoma. In closed angle glaucoma, mostly is induced from very thick lens for the size of the eye. Therefore, everything is squashed in the front of the eye. So I'm going to move on to the next slide. As it is demonstrated here, the lens is either moved forward or thicker than average. Therefore, that squashes the color part of the eye, and that jeopardizes the access to the drainage angle of the eye. Hence, it's called closed angle glaucoma as opposed to open angle glaucoma. As you can appreciate, there's a very close relationship between the cataracts and glaucoma. So there are certain types of cataracts or glaucoma which are related to the lens type. For instance, there is a type of glaucoma which is called pseudoexfoliated glaucoma, whereby the eye produces the dandruff-like material, whereby they can clog up the pores in the drainage angle of the eye, which we call them trabecular meshwork, and that cause the eye pressure to build up inside the eye. But the most common type of glaucoma is called primary open angle glaucoma. In these cases, even though the lens doesn't play a major role in inducing the raised pressure inside the eye, there is still a very close relationship between the cataract and glaucoma as well. And even doing the cataract surgery in these cases could improve the eye pressure by a little bit, not as much as seen in angle closure. So as I demonstrated here, you can see there is a close relationship between the structures within the eye. However, the closed angle glaucoma is more sight-threatening as opposed to open angle glaucoma, even though fortunately is less commonly seen in Western Europe and majority of European countries. In certain parts of the world, especially in East Asia, is one of the commonest types of glaucoma available, hence the role of cataract surgery. So there are various tests we do, as you might be familiar with, to establish the diagnosis of glaucoma and monitor glaucoma. So obviously this is the most favorite test, which I'm sure you're quite familiar with, is visual fields. I yet to see somebody who loves this test. So it looks at the functionality of the vision. Then we've got these tests on this printout on the bottom right-hand corner of your screen, which is called OCT, Optical Coherence Tomography, which uses the laser beam to look at the different structures within the eye. So essentially, this printout looks at the structure of the eye. The other printout on the top left-hand corner in the middle, a visual fields test, it looks at the functionality of vision. So we need to have both information available to make a judgment call about the diagnosis of glaucoma and also monitoring of the disease. And also, obviously, the only modifiable risk factor in glaucoma is eye pressure. Let me just move on. So, as you might be familiar with, unfortunately, glaucoma is mostly asymptomatic, unless there are certain types, for instance, acute angle closure glaucoma, whereby all of a sudden the vision becomes blurred, the eye becomes painful, red as well. But for most early glaucoma cases, the disease is completely asymptomatic, similar to high blood pressure. But there are other symptoms such as watering of the eye and blurred vision have been reported as well. There was a research paper published by one of my colleagues, David Crabb. He has done quite an extensive research into functionality of vision and visual field tests. So essentially, in this particular paper, they showed different types of visual field defect to patients, such as black tunnel, blurred tunnel, black parts, blurred parts, missing parts to patients, and asked them to see which one is assimilating the visual field loss and which one is closest to the patient's visual field loss. So when it comes to glaucoma, patients require more light because obviously in glaucoma, the nerve fibers which are located in optic nerve is like the analogy I usually give to patients is that the optic nerve is like a telecom cable. It has loads of wires within it, and each wire within it carries signals from the eye to the back of the brain to be processed in the back of the brain as images. So essentially for each image, we've got like a little pixels, which for each pixel carried out through those little fibers. So imagine some of those wires are damaged and missing. As a result, there would be some missing parts in the vision. Therefore, you may require to have more lights, the vision might be blurry, you may have glare and halo, and you may have difficulty seeing objects after both sides of peripheral vision. So if I move on to epidemiology of the glaucoma, there are a few questions. I'm just going to go through them. Are there greater risks after cataract operation of having glaucoma on other eye, as this is what happened after my first cataract operation? So, as I said, excuse me a moment.
Hi everyone, sorry about that. It seems like Pouya's got someone at the door. There you go, you're back. Great, thank you.
Excuse me about that. So essentially, as I said, there is a close relationship between cataract and glaucoma. And if cataract surgery is complicated, that can lead to raised pressure inside the eye. And obviously, if there is an underlying glaucoma, that may have a more impact on glaucoma as well. There is something we call it wipeout. So in advanced glaucoma cases, any intraocular surgery, any surgery within the eye, can cause whatever nerve left within the eye, within the optic nerve, can be damaged. So essentially, those fibers which are left within the optic nerve could be very sensitive and fragile to a change of pressure within the eye during the cataract surgery. Usually, the rest of the question is that I have got diagnosed with glaucoma, and I'm afraid if I get cataract in my other eye, it will go into both eyes. It's unlikely, because cataract, as I said, the cataract itself, a cataract surgery itself doesn't usually cause glaucoma. Mostly glaucoma is symmetrical. If one doesn't have any signs of glaucoma in one eye, there is a chance that it may present itself later on in the other eye, but there are some instances whereby glaucoma stays in just one eye and it doesn't show itself in both eyes. The next question is that if the pressure in the eye changes significantly due to surgical intervention, would you expect the vision to change? So as I said, it may not change immediately during the surgery, but it may change afterwards. But there are several ways whereby we can mitigate for that, such as we reduce the eye pressure significantly during the surgery by giving patients special tablets, we call them acetazolamide tablets, to reduce the eye pressure during the surgery and reduce the risk of fluctuation in eye pressure during the surgery, and also ask patients to carry on taking these tablets for a little while after the operation to make sure the eye pressure doesn't fluctuate and does not affect the glaucoma in those cases. Difficulty seeing in dark, it could be a symptom. It's called nyctalopia, mostly seen in retinal disorders, but in advanced cases of glaucoma, it has been reported as well. So is it normal for pressures to go up and down with outpatient appointments in glaucoma? So essentially, there is a physiological fluctuation in eye pressure depending on what time of the day we measure the eye pressure. The eye pressure could differ, but in normal individuals, these variations would not go beyond 5 millimeter of mercury, whereas in glaucomatous eyes, these fluctuations can go up to 15 millimeter of mercury. Generally speaking, the fluctuation in eye pressure is under control of corticosteroid hormones in body, which is highest in the morning. Therefore, the eye pressure tends to be highest in the morning compared to afternoon. Right. So there's one more question. Are there greater risks after cataract operation of having glaucoma on my other eye, as this is what happened after my first cataract operation? As I explained earlier, it depends whether the other eye has any signs of glaucoma or not, but directly cataract surgery does not, if it is straightforward, does not cause glaucoma in that eye. Is it possible that my visual field test result will improve after having cataracts removed from both eyes? There is a possibility that that blurred vision cause some interactions and some problems seeing the lights during the field of vision, and indeed doing cataract surgery would improve that cloudiness, and therefore that would improve visual fields. But there are some indices within that visual fields which tells us whether those changes are related to cataract or is related to glaucoma itself. So the next question is that, is there a statistical risk of having cataract operation on an eye with glaucoma 40 years? So there are lots of studies looking at the effect of glaucoma medication on cataract development. There are some weak evidence suggesting that using glaucoma eye drops, especially with preservatives, can cause cataract in animal models, but there's no proven evidence in humans. Doing certain types of glaucoma surgery, such as trabeculectomy or tube surgery, can accelerate the cataract formation in individuals who suffer from glaucoma. So the rest of the question is that the cataract surgery went wrong on the first eye. Now with no sight in that eye, I'm very sorry to hear that. Very concerned whether to go ahead regarding wipeout risk. So again, unfortunately, this is something you need to discuss with your own clinician. The risks and benefit of the procedure should be weighed out against each other to see whether it is wise to proceed with cataract surgery in those cases. Is closed-angle glaucoma very rare in the UK? It's not very rare, but compared to open-angle glaucoma, it's less prevalent. As I had this in the left eye 12 years ago, and it was not diagnosed at A&E, therefore my treatment was delayed by 24 hours. Usually, if everything else is healthy, the eye and optic nerve can withstand sudden rising eye pressure within 24 hours. My recommendation is to patients who have narrow angles is that if they develop any symptoms, they need to get in touch within 24, 48 hours. That's a golden time. And beyond that, probably the eye would not be able to tolerate very high pressures. Is having a shallow anterior chamber adding to the risk for glaucoma patients having cataract surgery? Indeed, that's a very good question, because remember, we need to introduce some instrument into the eye, which I'm going to show you a video towards the end of my talk about the cataract surgery. We use ultrasound energy to break down the cataract to smaller pieces to be able to take the cataract out. That ultrasound energy in shallow anterior chamber cases would be too close to the clear window of the eye, and that can disturb the clear window of the eye. And also because everything is just quite squashed, there is a high risk of running into complications. But again, we would mitigate for those things by taking extra measures during or prior to surgery. The next question is that, is it common to have a clear lens removed to help stabilize eye pressure? Just waiting for second lens removal. Indeed, there is a very recent clinical trial published, well, it was published 5 years ago, demonstrated the benefits of early clear lens extraction in cases of angle closure, but it was specifically designed for certain type of angle closure cases, not for everybody. But definitely it is a known treatment modality at the moment. So I have recently been diagnosed with advanced normal tension glaucoma, and I am on beta blocker eye drops, which have got my eye pressure stable. My next appointment with my ophthalmologist isn't for 6 months. Is this gap too long between appointment to check my pressures? Again, it depends on the severity of the disease and how quickly the disease is progressing. Again, your ophthalmologist would be able to tell you based on these measures. And if you have noticed new changes in your eyesight, please do get in touch with your ophthalmologist to bring your appointment forward if it needs be. All right, thank you very much for your questions. Shall we just carry on? And I'll answer the rest of the questions again further on during my talk. So there are some studies showing that by 2035, 1 million people in the UK would be suffering from glaucoma. And by 2040, there would be 118 million people globally suffering from glaucoma. And unfortunately, majority of these patients are located in sub-Saharan areas rather than in more developed countries. And as we all know, unfortunately, glaucoma is a disease of old age, similar to cataract. So they progress usually hand in hand. Usually in the UK, based on the consensus in 2016, the life expectancy for people who live in the UK is 72 years. So inevitably, a lot of us will develop glaucoma. It's just a matter of time. And also, obviously, the environment, the genetics, the structure of the eye, the anatomy of the eye would contribute to these factors as well. So as some of you, from your questions, you're a very knowledgeable group. There are different types of treatment modalities. Usually there's a stepwise approach to glaucoma treatment, starting from medical therapy, laser treatment, surgery. Usually medical therapy starts with eye drops. There are some new developments in the pipeline, such as special injections, which obviates the need for putting the eye drops in. Usually patients would have injection of the medication in a size of small grain of rice, which stays inside the eye for around about 3 to 4 months. And then patients require to have this injection repeated every 3 to 4 months, and in some instances every 6 months, similar to macular degeneration injections. There are some rings available whereby they have been impregnated within the medication and then put around the eye, inside the eye, to release and elute medication. And there are some similar sort of contact lenses available which do the same thing as well. There are new laser modalities available, such as selective laser trabeculoplasty. The guidelines, glaucoma guidance is about to change very shortly next year. So laser treatment could be offered as a primary treatment modality at the same time as eye drops. Again, this came on the back of new evidence from one of the large randomized clinical trials. There are other various types of lasers available, such as cyclodiode laser, usually reserved for refractory cases and cases whereby there is no hope for eyesight. There are a newer type of microscopic laser treatment, which is called ECP in short, endoscopic cyclophotocoagulation, whereby can be applied at the same time as a cataract surgery. So patients would get two benefits: not only have their eyesight improved, but also they would have the eye pressure improved as well. Then peripheral iridotomy, which is one of the treatment modalities for angle closure. And the next step would be surgery. In some cases, as some of the audience raised in their questions, cataract surgery could be curative in angle closure cases. Again, at the same time as glaucoma surgery, there are new devices available. We call them minimally invasive glaucoma surgeries, MIGS in short, whereby they can use during this cataract surgery as well. And then proper glaucoma surgery, such as trabeculectomy, deep sclerectomy, which would be under the umbrella of filtration surgery, and finally tube surgeries. So as I explained early on, there is a lot of interaction between glaucoma and cataract. Glaucoma and its treatment can cause cataract itself, such as trabeculectomy or tube surgery, because they change the balance of the aqueous humor within the eye, in especially trabeculectomy, or in tube surgery, if the tube is too close to the lens inside the eye, that can cause a cataract as well. And vice versa. Cataract can cause glaucoma, as I alluded to early on, in angle closure cases. And interestingly, cataract surgery could be a treatment option in glaucoma cases, either in open angles or closed angles. Obviously, it would be more effective in closed angle cases as opposed to open angle glaucoma cases. And the other issue is that sometimes in individuals who suffer from glaucoma and at the same time they had previous glaucoma surgery, especially trabeculectomy, doing cataract surgery can jeopardize the functioning trabeculectomy as well. Again, we use some extra precautions to prevent that happening by using some anti-scarring medication at the time of surgery or afterwards to encourage the trabeculectomy to function afterwards. But sometimes, despite all our efforts, the trabeculectomy can fail, and this is due to the nature of the cataract surgery and the inflammation which is created during the surgery as well. And finally, cataract surgery can be combined with other procedures such as mixed surgery, minimally invasive glaucoma surgeries. Again, I'm going to show you a few videos on these surgeries as well. So before I put up the cataract surgery videos, let me go through some of the questions. My mom has glaucoma, and I have been told I am a glaucoma suspect. As glaucoma is not genetic, could my traumatic brain injury be a factor? Actually, glaucoma tends to run in families, and there are several genes. There have been several genes identified which can contribute to glaucoma. Brain injury itself cannot cause glaucoma, but if the traumatic brain injury involved head injury around the eye, sometimes that trauma can damage the drainage angle of the eye. We call it angle recession, and that can cause glaucoma, or sometimes displaced lens can cause cataract as a result of trauma as well. Glaucoma is always referred to as a disease for older age, but I have moderate glaucoma in the left eye and early glaucoma in my right eye, and I am 50. How likely is it I will lose my sight, and how soon will it happen? That's $1 million question. It's difficult to know, unfortunately, but if generally speaking, glaucoma progresses very slowly, and if it is captured early on, there is a good chance that you will outlive your condition. So the key in glaucoma is have regular monitoring about glaucoma. There are some evidence emerging that if you have an active lifestyle and do regular exercises, that can improve the blood flow to the optic nerve and reduce the progression of the disease. And therefore, that individual can maintain their eyesight longer, and the glaucoma could be managed better. Also, healthy lifestyle could be effective in glaucoma as well. Which eye drops are best with or without preservatives? So my motto is that the less toxins, the better. But there are loads of caveats in that. Preservatives are there for a reason. Number one is to keep the active ingredients sterile and stop bugs getting into the bottle of the eye drop. That's one. Number two, preservatives act as detergents to allow the medication to penetrate into the eye better. So at the same time, it comes with a price, because that disturbs the surface of the eye to allow medication to penetrate into the eye. That can cause soreness, red eye, and discomfort. But not all redness, discomfort, and blurred vision are due to preservatives. Active ingredients within the medication can contribute to these symptoms. On top of that, buffers within the medications can contribute to these symptoms as well. There are some eye drops in developments. They are called micro eye drops. So the size of current eye drops is around about 10 to 15 microliter. Those eye drops, there are just 3 to 5 microliter, but they're as potent as the conventional eye drops. But again, they are in the research aspect at the moment. I have recently had a trabeculectomy with subsequent needling. So essentially needling is whereby there is an excessive scar formation around the surgical area, and the ophthalmologists try to break that scar tissue to encourage the fluid to disperse better around the eye. Was not concerned, the ophthalmologist was not concerned about the beginning of cataract. However, 2 opticians recently have said, I have very bad cataracts which require surgery to improve my vision. So again, as I alluded earlier, cataract is an aging issue, and it can happen to all of us. It's just a matter of time. Just having a cataract per se doesn't mean the cataract should come out and that individual should have cataract surgery. But if that individuals have symptoms, difficulty doing the chores, troubled doing the hobbies, then that's about time to do cataract surgery. Obviously, there are some clinical indications to do early cataract surgery, such as angle closure cases. but on average, we tend to do cataract surgery when the patients are troubled enough with their current vision. But again, if you're concerned about cataract, I think it's not a bad idea to discuss that with your ophthalmologist and take the optician's report to them and discuss this with them. Can working on the computer affect my glaucoma? No, it does not. So the little issue is that the glare and halo, which can come from very bright screen, can be troublesome in cases of advanced glaucoma. Okay, so let me just see, and there's some chats going on as well. Sorry, I missed all of them. Okay, so bear with me a second. Let me just share my videos with you. If I can, it's a new share. So this is a typical cataract surgery.
Pouya, it hasn't shared for some reason. So if you do what you did before, so if you stop sharing and then try again, I think we're having the same issues that we had before.
Sorry about that.
That's all right.
Okay. Can you see the video now?
No, unfortunately, it's still the file explorer thing.
Okay.
So I think if you have the video open and then share again onto the video.
So this is a very well dilated pupil. And what you see, the red thing you see here, we call it red reflex. And you can see there are some patches of some mistiness there, which is essentially, that's the cataracts. So obviously the history of cataract surgery goes back to 1,000 years ago. We've come a very long way. At the moment, the cataract surgery done through very small cut around the eye, around about 2.2 millimeters. So it's very, very tiny. So I would like to just imagine that that's a very tiny area we go inside the eye to perform cataract surgery. So there is some medication to keep the pupils open and reduce the pain, some anesthetic medication. Then, as I showed you early on, the lens is surrounded by a little membrane. In order to be able to maintain the space within the eye, we put some jelly inside the eye, we call it viscoelastic. Then we make a little opening on the front of that membrane, we call it capsule. So in a second, this is the second cut around the eye, which is around about 2.2 millimeter. You need to keep the eye moist because we keep the eye open with these props here. You can see these metallic pieces on the bottom of your pages, screens. So that's a tiny membrane, it's just few microns. It's extremely thin to be able to access the lens material. Obviously, we use different instruments to be able to do that. So that thin membrane is peeled off from the front of the lens to be able to have access to lens material. then remove the gel within the eye. I dislodge the lens by injecting little liquid, which goes all the way around the lens. Then this is called phacoprobe. So it's phaco means lens. So essentially, the full name for it is phacoemulsification, which means that this probe does three things. Not only emits ultrasound energy, but also irrigates the eye and also aspirate all the debris from the eye at the same time. So what I'm doing here, I'm just getting rid of these air bubbles, which is getting in my way. Then I try to cut through the lens to be able to break it into two hemispheres. There you go. I turn it around to break it into even smaller pieces. But this particular cataract is very soft, so I'm able to just take it out in one go. So it looks like the entire lens material would like to come out. So essentially, this cataract was waiting to be taken out, really. Again, my assistance, it's not my third time. My assistance is just moistening the cornea so that I maintain my view of what is happening within the eye. Because just bear in mind that that membrane, which I made an opening in the front, it goes behind the lens as well. And again, that is a few micron thin as well. There is a great risk of breaching that membrane, which means that the cataract surgery could be complicated. Now I'm trying to remove all the debris within the lens capsule to prepare a new bed for new lens to put inside the eye, replacing the cataracts. So just remember, initially everything was essentially, the analogy I give patients is that it's like a dirty screen, dirty window, and now I'm just trying to clean up the entire window to put the new lens in. This is the new lens, which is very tiny, tiny lens made of plastic. And just make sure it is in the right position. And nowadays, cataract surgery is completely sutureless. I just inject a little bit of water within the cornea to create a little bit of swelling to seal off the cuts I made. And in the end, I finish off the operation by giving some injection inside the eye. So that's about cataract surgery. Any questions about cataract surgery before I move on to the next slide? So is it ever too late to do cataract surgery operation? I've been told not. That's correct. It's never too late to do cataract surgery. Although if you wait too long to cataract become extremely rock hard, we call it a brunescent cataract or white cataract, although technically it's not more difficult, but it comes with high risk of running into complications. But with the current advanced technology, it doesn't make the operation more difficult. Okay. So the next thing I was going to show you is one of the devices which you can put inside the eye during the cataract surgery. I wonder if you can still see my presentation at the moment?
No, it's still the end of the cataract surgery.
Let's go back there. Okay, so here's another animation about one of the devices which is called iStent. There are different types available. So this is an animation to demonstrate that aqueous humor is produced within the ciliary bodies, travels through the pupil, enters through the front of the eye, reach the drainage angle of the eye, and drain out through these little pores, which are called trabecular meshwork from the eye. So during the cataract surgery, you can put these little stents, which are similar to cardiac stents, into the trabecular meshwork to bypass the trabecular meshwork to improve the eye pressure. Obviously, there would be horses for courses. These stents are not suitable for all eyes. They have to have a specific configuration, the drainage angle of the eye, i.e. being completely open without any signs of damage or scar formation. So this is how it looks like. It is made of titanium. It is MRI safe. They're tiny, tiny ones. So this is just to demonstrate how small they are compared to 1 cent, as this device company is based in US. So again, this shows how being implanted, we use a special injector, use a special prism to be able to visualize the drainage angle of the eye, and then we put these stents within the drainage angle of the eye. There you are. Okay. So I just wanted to talk a little bit about the York Glaucoma Patients Forum. So essentially, each hospital tend to have a Glaucoma Patients Forum, which is usually supported by either local charities or most often than not, Glaucoma UK have been kind enough to sponsor these forums for patients to be able to voice their concerns and meet like-minded patients within that forum. So we are in the process of developing that with the help of Glaucoma UK and your site, which is a local charity in York. There are a lot of supports available, RNIB, Glaucoma UK, and Fight for Sight. So I talked about what is happening at the moment, but there are loads of things happening for future. As I briefly alluded earlier on, there are some injectable implants available whereby that obviates the need for taking the eye drops regularly. And also there are some home monitoring devices available which could be implanted at the same time as cataract surgery or could be used as handheld devices afterwards. So one of them is Eye Care Home, which we are fortunate enough to be able to have access to this in York Hospital. We lend out this device to patients to measure their eye pressure and then bring them back the device to us. We connect this device to the computer, and that gives us the measurement of the eye pressure throughout a couple of days where patients have been measuring their eye pressures. The next one, which I'm going to share with you, is implantable medications. So essentially exactly similar to macular degeneration injections, but instead of going to the back of the eye, these little implants, as I said, smaller than a grain of rice, goes in the front chamber of the eye, and they have to be repeated every now and then without the need of using the eye drops. And that usually sometimes reduces the risk of some of the side effects as a result of taking topical eye drops. Again, we are fortunate enough to be able to be part of the clinical trial for this particular implant in York. And I hope this was a whistle-stop tour about the interaction between glaucoma and cataract. I hope I managed to answer some of the questions. I'm happy to take more questions. Can see there are a few more coming. What is the incidence of failure after cataract surgery? I gathered what is the incidence of failure of trabeculectomy after cataract surgery. Again, the risk is round about between 20 to 25% chance. But again, we mitigate those risks by using some additional anti-scarring medication and using more steroid medication afterwards. I had eye stent, ECV, and cataract surgery simultaneously last year. About 3 weeks later, my vision deteriorated in that eye. Could the new lens have moved? It's unlikely. One of the downsides of having laser surgery at the same of the cataract surgery is the risk of developing waterlogging in the back of the eye. We call it macular edema, which requires a little bit longer term post-operative management to get on top of this. So again, if you have noticed your vision is deteriorating, it's not a bad idea to get in touch with your ophthalmologist. You may require to have some scans of the back of your eye to make sure there is no waterlogging in the back of your eye. Can eye stents be used instead of cataract surgery to prevent closed angle glaucoma where the cataract is thickening? Unfortunately not, because these stents would not push the mechanical side of the angle closure away. And as I showed you in the earlier video, let me just go back. Sorry about that. Let me show you the video again. So in eye stents, all we do, we access the trabecular meshwork and enhance the drainage. So essentially, if I'm going to give you an analogy, you've got a basin with the running water, but the hole is small. If you enlarge the hole, you get more drainage through that basin. That's exactly a similar concept. But again, it does not get on top of the lens, which is squashing the entire structure of the eye. Stents go only in the drainage angle of the eye, but the pressure and the mechanical pressure comes from the lens. So the cataract surgery would be the answer.
That was such a fascinating talk. You've covered a lot of information there. I'm just wondering if you could explain very simply why an eye stent or similar MIGS devices are often done at the same time as the cataract, because they're quite separate, aren't they? And they act in different ways.
Yes, that's right. So essentially, there are a few arguments about using these MIGS devices. Most importantly is the cost involved. So there have not been any cost utility analysis for these devices. The eye stents cost around about £1,200. For ECP, the ECP is the cheapest one available in the market. So round about, for each usage is around about £100 or less. But essentially the indication for majority of these mixed devices are, all of them have been approved to be used at the same time as cataract surgery, but some of them can be used as standalone without cataract surgery. But again, there are different types of mixed surgery available. Some of them bypass the trabecular meshwork, such as eye stent. There is another one which is called Hydros. Again, that is like a scaffold, goes through the trabecular meshwork, expand the trabecular meshwork, allows the fluid to travel through the trabecular meshwork better. So the reason we use these bypass devices is that the majority of the resistance within the drainage angle of the eye is located at the trabecular meshwork, around about 75% of it. But there is another 25% beyond trabecular meshwork, such as this area, we call it Schlemm's canal, and beyond that, because what happens is this liquid goes to the lymphatic system of the lymphatic system and get absorbed into the systemic circulation and then get reused, similar to blood flow through the heart and kidneys as well. Therefore, there are different types. Now, when it comes to laser treatment, that can be used because that would be directed on the amount of fluid which is produced inside the eye by directing the laser treatment through the ciliary bodies. So that is one of the only mixed surgeries which targets the ciliary bodies rather than, so targets the production of the fluid rather than the drainage of the aqueous humor. Therefore, the endoscopic cytophotocoagulation, in short, ECP, can be used in most eyes, whereas the eye stents and other similar devices whereby which bypass the trabecular meshwork cannot be used in certain eyes, such as in angle closure cases, or the eyes whereby they already had some damage in the drainage area of the eye.
Great.
It was a long-winded answer to your question.
No, that was very, very informative. Thank you. I'm aware that it is 7 o'clock. We haven't managed to answer all your questions. So I'm very sorry about that, but we will have to wrap up now. So thank you so much, everyone, for joining us. I'm just going to launch our last poll. So that is just understanding how much we have learned from today's session. So thank you, Pouya. You covered a huge amount of material then. That was very, very informative. Thank you so much. Really appreciate it.
Thank you.
And I'm just going to take over the screen sharing quickly so I can put our last slide up. So, yeah, thank you so much. If we didn't manage to answer your question today, and I'm aware we didn't, particularly the ones that came in through Facebook, so very sorry about that. But if you haven't had your question answered in today's session, or maybe you did, but you still want a bit more information, please do contact our helpline. The contact details are available on the screen now, and our staff will be very happy to help you. Or if you've learned something in today's talk and you want to know a little bit more about them. So if you have any questions about cataracts and glaucoma, or just glaucoma, please do get in touch. So this is our second to last talk before Christmas, and the next one, so the last talk for 2021, is all about glaucoma and driving on the 16th of December at 7 p.m. We have Dr. Josie Forte from Specsavers to talk about how glaucoma affects your ability to drive and how your vision is tested for driving if you have glaucoma. And we're busy planning our talks for early 2022, and we've got talks coming up on normal tension glaucoma, living with glaucoma, how pharmacists can help with your eye drops, and lots more. So you can visit our website or call our helpline for more information and to register. Pouya also mentioned some topics which we've covered already in talks as well. So he talked a little bit about laser treatment and what your vision looks like if you have glaucoma, and eye drops. All of those previous talks are available on our website or our Facebook page. Please do watch. There's loads of information in there for a lot of the things that came up as well in today's talk. So thank you again, Pouya, for a really fascinating talk. We learned, well, I'm sure everyone in here learned a lot. There was an awful lot covered. So thank you so much. Thank you very
much, everybody, for joining in.
No, it's been a pleasure having you with us. When this webinar ends, there will be a survey that launches. So please do take a few minutes to fill that in. We really read that feedback that you give us really carefully to help us plan our talks. And we really want these sessions to be helpful for you. So the more feedback we receive, the better those sessions will be. So please do take the time. And thank you so much for spending your evening with us. We've really enjoyed the talk. So thank you, Pouya, and thank you. Goodbye, everyone.